So hello friends and welcome back to my channel. Today I'll be discussing about Kawasaki disease. The reference is again from Nelson's textbook of Pediatrics 21st edition. So in this video I'll be discussing about the introduction, pathology, clinical manifestation and about the lab findings. So Kawasaki disease, which was formerly known as the mucocutaneous lymph node syndrome and as the infantile polyarthritis nodosa. So, highest incidence is seen in the Asian children. Now let's move to the pathology of Kawasaki disease. So it predominantly affects the medium-sized arteries, mainly the coronary artery, which is the most commonly involved. So clinically we see three phases. So first phase is about the neutrophilic necrotizing arthritis. It is basically seen in the first 2 weeks of the illness, and saccular aneurysms are also seen in this phase. Second phase is subacute chronic vasculitis driven by the lymphocytes, plasma cells and eosinophils, lasts for weeks to years, and fusiform aneurysms is seen. Now these fusiform aneurysms affects a vessel, and that affected vessels then forms the smooth muscle cell myofibroblast, which results in progressive stenosis. So moving to the clinical manifestations. So there is high fever, which is remitting and unresponsive to the antipyretics, plus 5 principal criteria. So the first is the bilateral non-extudative conjunctival injection with limbal sparing. Second is the erythema of oral and pharyngeal mucosa with strawberry tongue and rare cracked lips. The third is the edema and erythema of hands and feet. Fourth is rash, and fifth is the non-suppurative cervical lymphadenopathy, which is basically unilateral. So other symptoms apart from this is the perineal desquamation, which is very commonly seen in the acute phase. Second is the periingual desquamation of fingers and toes, which is seen in second to third week after the onset of illness. So other GI symptoms and some respiratory symptoms are as follows: vomiting, diarrhea, abdominal pain, so which is basically seen in 60% of patients. At least one of the respiratory symptoms, rhinorrhea cough, is seen in 35% of patients. Other is arthritis and cardiac involvement, which is very important. So one of the important points here is that up to 25% of the untreated patients develop coronary artery abnormalities. So now I'll be talking about the three phases which is seen clinically. First is the acute, subacute, and the third is the convalescent. So in first phase, that is the acute phase, fever, other acute sign, and which lasts for 1 to 2 weeks. Subacute phase, desquamation, thrombocytis, development of coronary artery embolism, the abnormalities, which last for 3 weeks. In convalescent phase, which begins when all the clinical signs of illness have disappeared, and it continues until the ESR is normal, which lasts for 6 to 8 weeks. So the lab findings, so there is no diagnostic test, but basically the leukocyte count is elevated, normocytic normochromic anemia is seen, platelet count is normal in first week, but then it increases rapidly by second to third week, and ESR and CRP are also elevated. So stay tuned guys for the next video, the next part regarding the diagnosis, differential diagnosis and treatment. Thank you.